is Caleb from TASC at the National Rural Health Resource Center, and this is our February TASC 90 webinar, where we have Dr. Jane Peterson from Stratus Health to chat with us about some quality improvement measures and the history and integration of the process improvement in healthcare, differences between outputs and outcomes, and we will hopefully discover where outputs and outcomes fit into the FLEX program work and the activities that you can work with in your program to do that. But first, we have a few updates and a few updates. And we'll hear from Sarah Young from the Federal Office of Rural Health Policy, Carla Wang from Stratus Health, John Gale from the University of Southern Maine at the FLEX monitoring team, and yours truly from TASC. So I will start with some TASC updates, just to let you know some of the things that we're working on right now as we're all ready for spring, I think. We're planning the reverse site visit, and registration should be open for that in early May. The cybersecurity toolkit has been updated and is available on the TASC website. Last week, we had a face-to-face meeting of the National Rural HIT Coalition, and if you're interested in participating in the coalition, please send an email to task@ruralcenter.org. We are working on planning and updating our agenda for the spring FLEX workshop in April up in Duluth. A reminder that the deadline for the critical access hospital recognition is the 23rd, so next Friday. Any facilities that have implemented innovative initiatives integrating behavioral or mental health that are worthy of recognition, please send those nominations in. There's a form that can be found on the TASC Critical Access Hospital Recognition website. And we've completed the annual update for the Fundamentals of FLEX program, and it is available online, and a paper copy will be mailed to each FLEX program shortly. If there are no questions on any of the TASC updates, I will let Sarah and or Joaquina from the federal office provide their update.
Were you able to join us, Joaquina?
Star 2 will unmute your line.
Joaquina is at an off-site conference.
Sorry, I had to unmute myself. As I thank you for the quick reminder. I was able to join. It just kind of logged on quickly after getting online. So I am here. Sarah wanted me to do the update.
Great. Go ahead, Joaquina. Glad you could jump on.
Okay, so I'll just go ahead and jump right in. I provided just a couple of updates for policy updates for your reference. The first, just a quick reminder, if you haven't already heard about the cancellation of the cardiac care episode payment model and some of part of the extended CJR model that CMS had passed in 2016 or put out in 2016. So what they're now doing is making the CJR model, at least for some of the hospitals, voluntary and allowing rural hospitals to come in. That time period for selection or for rural hospitals to indicate that they wanted to join such model was in January. So again, this is just more so that you're aware of this particular change, and I provided a link to the fact sheet. Also wanted to make you aware of, if you weren't, that the advisory panel for hospital outpatient payment has a ongoing request for nominations for representation on that panel. As it relates to CAS in particular, they're interested in members that can advise CMS specifically regarding the level of supervision for hospital outpatient therapeutic services. So with the understanding that CAS are not paid under OPPS, again, representation on that panel for supervision for hospital outpatient therapeutic services would be helpful for CMS. So, we encourage you to kind of spread the word among critical access hospitals in your states regarding this opportunity. I also wanted to share with you the Medicare Electronic Health Records Incentive Program fact sheet for CAS that CMS has recently released as well too. So again, they just wanted to provide an overview and of this particular program to make CAS aware that they will be subject to a downward adjustment to their Medicare reimbursement for inpatient services unless they demonstrate meaningful use under the Medicare or Medicaid EHR incentive program. And what they do is kind of lay out what those payment adjustments would be according to the fiscal year. And so most recently for fiscal year, for example, 2016, they would have an adjustment of, their reimbursement would be reduced to about 100.33% of the reasonable cost. So just something that you should be aware of. And there is a new bundled payment that CMS recently announced that, and one of the things that we did notice is that CAS are excluded, and CMS gives the reasoning based on how they receive payment. But I think this is just something for, as flex coordinators that you should be aware of. There is some interest that we've heard from stakeholders in this particular program, and also some concerns. I know that some folks feel like there wasn't enough operational information that was released from CMS, so we're just monitoring this to see where this will go and how CMS plans to ultimately implement it, but they did indicate that this would be something that would qualify for an advanced alternative payment model under the quality payment program. And then finally, I just wanted to bring to your attention some updates to the policy manual for rural health clinics and FQACs that CMS put out. I know a couple of those updates relate to their billing for care management services, or what they're now putting under the broad bucket of care management services, which are those updates related to chronic care management and the behavioral health integration services, as well as the psychiatric collaborative care model. So now rural health clinics, particularly if CAS have provider-based rural health clinics, they should be aware that those are some of the services that their RACs are able to bill for now. And also I wanted to bring to your attention that our advisory committee recently did a site visit and published a brief on modernizing the rural health clinic program or policies as it relates to rural health clinics. A couple of the things that they focused on were payments, particularly for those RACs that are independent or are affiliated with hospitals with more than 50 beds, so not necessarily your CAS or your provider-based RACs that are owned by CAS, but again, they were kind of looking at the RAC program in general and suggested in their paper, or recommended in their paper, in their brief to the secretary, that how RACs are paid, particularly the ones that are under a payment cap, should be reevaluated, re-examined to make sure that that payment that they're receiving is adequate for the actual cost of the services they're providing. They also did some recommendations for looking at lab requirements, workforce, such as the type of behavioral health providers that can work in a rural health clinic, as well as some type of program support for RACs. So one of the things that we've had a lot of conversations about is how do we get RACs more engaged in quality reporting and this movement towards value-based payments, and knowing that they have a lot of operational technical issues to overcome and just their ability to be able to do more quality reporting. One of the things that the committee did note is that unlike health centers that are HRSA grantees and critical access hospitals that receive funding or technical assistance through the FLEX program, there was no such type of program for RACs, and so again, that was part of their recommendations to the Secretary. Now, whether or not the Secretary chooses to act on it, on these recommendations, we're not sure, but it is something that the committee definitely felt that should be brought to the Secretary's attention. And so those were just a couple of the updates that I wanted to bring to your attention for this particular update.
Thank you, Joaquina. Were there any questions for Joaquina about these policy updates? Seeing none, I'll remind everyone that as well as the policy updates on these TASC 90 webinars, Joaquina provides us an even more detailed policy update every month for the Rural Route newsletter, and that's also posted on the TASC website. So that is a great way to stay abreast of policies coming out of the Department of Health and Human Services that may impact your programs and your stakeholders. And of course, if you want even more frequent updates and you're not already, the weekly announcements email from the Federal Office of Rural Health Policy includes significant rural policy updates from that Joaquina and the policy team identify. So if you are not receiving the 4 weekly email and you are interested in signing up, just let me know and I will send you the sign-up link. So with that, that's our policy updates for this month. I did want to thank everyone. All but 2 of the federal financial reports for the FY16 grant year have been reviewed and approved in EHB, and all 45 of them were turned in on time. So that was excellent this year, that everything was very timely. As you know, carryover requests, the last date for carryover requests is 30 days after the FFR was due, or at the very latest March 1st. But really encourage people not to wait that long. If you have a unspent funds that you would like to request this carryover, talk to your project officer now and get that process moving forward. Was someone trying to ask a question? Just some background noise. Okay. I also wanted to remind folks that we had a couple of good Flex program webinars in January, and the recordings are posted on the TASC website in the past events link. January 18th, we held a Flex Looking Ahead webinar that introduced the Flex Data Explorer tool that I've been working to develop. And then January 25th, we had a Flex PIMS Data Report Out webinar reviewing the PIMS data you all reported for the FY16 grant year, so last year's PIMS data report. Are there questions about that or any of the other ongoing Flex program activities and deliverables? And I see Bridget posting the links in the chat box. Thanks, Bridget. Okay, I think I can pass this over to Carla. Hello, everyone. Can you hear me okay?
Yes, we can. Thank you, Carla.
Okay. Thanks, Caleb. So just a couple of brief updates on the MB-Equip front. Some tools and resources. We are continuing to enroll critical access hospitals in the Abstracting for Accuracy program. That's the opportunity for your critical access hospitals to do a validation or an inter-rater reliability process with Robin Carlson from our office. So they would send her copies of their abstraction and the charts, and then she would check against them. So it's really, the focus is on helping better make sure that as long as they're putting the time and effort into collecting that data, that it's actually collected accurately and consistently. So we are still enrolling critical access hospitals now, and there's the link to the promotional materials that you can send out there in the slides. Another update related to measures, we're in the midst of an emergency department technical expert panel process. We started that work in January of 2018 and we'll be doing recommendations later this spring. We have about 9 or 10 folks from around the country, a variety of disciplines, all with kind of backgrounds and expertise related to rural emergency department care or rural hospitals, talking about the emergency department transfer communication measure and whether or not it needs to be updated, changed, what kind of things we might do differently with that measure if it's still getting at the types of things that it was developed for. So we'll have more information coming on that as we get the recommendations on where to go with that panel. The University of Minnesota Rural Research Center is our partner in that. They are the Emergency Department Emergency Department Transfer Communication Measure owner. So they're the ones that work with the National Quality Forum for the endorsement of that measure, and we're facilitating that with them. We're also wrapping up a pilot related to ECQM submission, or electronic clinical quality measure submission, trying to understand critical access hospital technical assistance needs related to that. That actually leads me to my next announcement. We are going to be talking more about that pilot tomorrow on the MB-Equip Virtual Knowledge Group, just providing some updates, and it does tie back to the comment Wakina made about the critical access hospital meaningful use requirements and whether or not they're going to start to take a payment hit if they're not meeting meaningful use criteria. ECQM, or electronic clinical quality measures, are one component of the meaningful use criteria. So the way that hospitals submit those is starting to change, so we're trying to better understand that. We do have the virtual knowledge group tomorrow. We're going to be focusing on using patient and family engagement to help support HCAHPS improvement. Kansas has done some really interesting work in this area, so they're going to be sharing their story. We'll talk about the ECQM pilot. We'll have several other updates, as well as just an opportunity for flex coordinators and or their MB-Equip subcontractors to have some dialogue and discussion around MB-Equip implementation. The next slide, please. Thank you. Just a reminder of a couple recently updated resources. The MB-Equip reporting guide has been updated to reflect all of the new MB-Equip measures, so the ED1, ED2, the antibiotic stewardship. It also has notations about the outpatient measures that are being retired. We've done the same with the Critical Access Hospital Quality Improvement Implementation Guide and Toolkit, so updated that to be reflective of the new measures. We also took and did a little bit of a rearrangement with that guide. We had a whole table of the measures and best practices for each measures embedded in the guide, and we actually pulled it out as a separate resource on that page, so it maybe is easier to find. So if you're looking for best practices on the individual MB-Equip measures, that is a great resource for you to go to. We do have in process a couple of things that will be coming out very soon. One that actually I think just got posted today is this Flex Resource Guide using patient engagement and family strategies for HCAHPS improvements. That's the summary of the Kansas story that you'll be hearing more about tomorrow if you're on the MB-Equip Virtual Knowledge Group. We will have a critical access hospital specific resource list related to electronic clinical quality measures
available. And then we're in the process of updating the Interpreting MBQIP Hospital Data Reports Guide to align with the changes that have been made to the MBQIP measures. So some of the things that we're working on here related to MBQIP. If there's any questions or comments?
Thank you, Carla.
Thank you.
And John, I think I saw that you were logged in. Were you able to get called in? Your star 2 will unmute your line.
I am on the line, Caleb. Thank you.
All right, thank you. John Gay, University of Southern Maine, from the Flex Monitoring Team.
Well, I appreciate it, Caleb. I'll just provide everyone with some updates on the Flex Monitoring Team activity. One that it saddens me to announce, but we wish her well. Many of you know, I'm sure, Michelle Casey. She has formally retired from the Minnesota Rural Health Research Center and the Flex Monitoring Team. I believe she'll be doing some limited work with them later in the summer, but she's been a big part of the Flex Monitoring Team for quite a long time and responsible for herding the rest of us cats, and she will be missed. Megan Lahr is coming in and taking her place, so if you have a chance to meet Megan, please welcome her. So we have a couple of things that are underway and that we've done over the past quarter. The Compass data set is adding a new reporting feature which allows users to download the hospital financial data set into an Excel spreadsheet. We're not at a point where you can download some of the quality and community information. Part of that has to do with the very significant differences in the data sets, and at least partially on the community side from a need to protect the American Hospital Association data that we use we have limited ability to release publicly. During the last quarter, we've also held 2 sets of webinars for the participants in Program Area 5, which is the integration of innovative healthcare models. The webinars were really designed to help and to provide a vehicle for the participants in those states that have the innovative models to interact and learn from one another. We currently have 2 members of the FMT serving on the PIMS Improvement Work Group that Sarah Young has organized. We've developed and will be putting into a more structured policy brief, a framework for looking at the prevention, treatment, and recovery strategies that are appropriate for critical access hospitals. We presented that in a framework in a webinar on the Rural Health Research Gateway, and we'll be presenting it. Kentucky is doing some really interesting work with part of their supplemental funding, and they're holding their first and inaugural Critical Access Hospital Substance Abuse Summit in March. So we'll be sharing the framework with that as well. In terms of products, we posted an interim evaluation report of the innovative projects. It was posted to the FMT website in January of this past month. In December, we posted the patient experiences in CAHs and HCAHPS results from 2016, a data summary report. And in November, we posted a policy brief on the EMS assessments undertaken by the states as part of their Flex program activity. Finally, the last piece that it will be up and posted to our website shortly are the national and state quality measure reports. So they should be due and posted by the end of this month. In a nutshell, we've been busy, so that's what we're doing. I don't know if there are any questions.
star 2 will unmute your line if you have any questions for John. All right, hearing none, I will introduce our presenter, Dr. Jane Peterson. She is the Chief Medical Quality Officer for Stratus Health, an independent nonprofit organization located in Bloomington, Minnesota, that focuses on healthcare quality and safety. In this role, she provides leadership and clinical guidance with health initiatives across healthcare settings. Dr. Peterson attended the University of Minnesota for med school and residency and is board certified in internal medicine and geriatrics. She also has a master's degree in health services research and policy, also from the University of Minnesota. In addition to working with Stratus Health, she has the opportunity to maintain a clinical practice with Illini Senior Care Transitions, serving as the primary care physician for residents in the assisted living setting. So please join me in welcoming Dr. Jane Peterson.
Thanks, Caleb. Can everybody hear me okay? I guess if you don't say anything, you're muted, so I'll just take that as a yes. I think my other thing I wanted to mention is that a little bit of my history. This work, I don't get to do a lot of work with Carla in rural health, but I do have a history that goes back with critical access hospitals. In fact, I was born in a hospital that is now a critical access hospital, and so I had the opportunity working or growing up in a small community to kind of see how the hospital and the community interact, and really didn't get a chance to be in a larger secondary or tertiary hospital until I was in training, and found that, really there is, when people say that there's a difference with rural health, it's not a difference in the quality of care that people should expect, but there is a difference, I think, in how healthcare and the community interact with each other. And I always feel bad that we don't get more chance for a lot of physicians who maybe grow up in a large metro area, train in a large metro area, and don't really get a chance to see how healthcare can be delivered differently in other settings. So just a little background that have some rural roots out there. I'd also just like to thank everyone for filling out the little survey that was up on the line here as far as your experience with outcomes and outputs. When I talked to Caleb about this presentation, he said a lot of you are coming from different backgrounds, some very familiar with working in quality, some maybe from backgrounds where that wasn't as much of what you do. So I'm trying to kind of hit a mix in my comments of things that hopefully is going to be things that are familiar to everybody, hopefully some things that for those of you that have had a lot of experience may look at something in a little different way. For those of you who maybe haven't had as much experience, maybe give you some tools and thoughts to take back to your work. I look at your group as similar to our QIN, QIO colleagues. We're in a position of not necessarily, we're not being the healthcare providers, but being there as a support and a guide to those organizations that are actually providing health, in your case, the critical access hospitals. So that's just my 2 cents to start with here. So I think a lot of you probably know through Carla who Stratus Health is. We're an independent nonprofit in Minnesota focusing on leading collaboration and innovation in quality and safety. And so often find ourselves kind of on that intersection between what's out there in research, what's in policy, and what's actually going on in practice. And how do we help people move what's going on in research, policy, best practice to what they're doing on a day-to-day basis. And this is just the objectives of what we're hoping to cover today. A little bit, I wanted to talk a little bit of some of the history and theory, because as Caleb and I were talking, I thought that might be helpful just to kind of ground us all and kind of bring us into this topic, and it kind of sets the stage for talking about what this difference in outputs and outcomes can really be. And then hopefully some of my comments will give you some ideas of how they can actually be thought of in your work with the FLEX program. First is just a terminology, and I noticed when Caleb and I were talking, when I would say quality improvement, I think sometimes he was thinking performance improvement, and this is just one of those things, I think, in this whole realm of improvement work, there's just a lot of terms, and oftentimes our organization may have one way of speaking about it, another organization may have another, and we're not all very consistent. So we talk about quality assurance, we talk about performance improvement, we talk about quality improvement, we talk about patient safety, we now hear more about diagnostic safety, diagnostic error, we hear about high reliability, then we talk about various models like Baldrige and Lean and et cetera, and it seems like everyone's, are these different, are these the same, how are these all relating to each other? In my mind, they all come under that umbrella of improvement. I'm personally guilty of kind of interchanging performance improvement and quality improvement, and it's probably something I should be more consistent with. When I talk about either of them, I'm talking about just the overall, how are we trying to close that gap between what we'd like our performance to be and where our performance is, and what are those tools, techniques, approaches that we do to close that gap. That can be at the organizational level. It can be talking about not necessarily clinical things, but talking about your performance in customer service, in finance, in those areas, or clinical quality improvement is kind of that realm when we're talking about those, how do we do better clinically? How do we achieve better outcomes? How do we better match our practice with best practices? Quality assurance, I talk about, is more that how do we monitor for those outliers whenever we don't want to fall below that minimally acceptable standard of care. And then I think, the role of safety and things all also fall under that improvement umbrella. But I think people would probably differ with that. But that's just kind of, so if I slip in this talk and I maybe say performance improvement or quality improvement, I'm going to try to just say improvement to keep it simple, but I'm going to apologize ahead of time if I slip and be a little sloppy in that terminology. This is a slide I kind of like to share just to kind of get everybody kind of thinking along the same lines when it comes to quality and kind of this difference between just improvement and assurance. The graph on the left is kind of your just bell curve of pretty much how oftentimes we are in anything we do. There's kind of that curve may be wider or narrower. There's the folks on the high end, the better end, and the worse end. And then at some point in there is kind of that minimal standard of care, kind of that tail where, nope, yeah, maybe we tolerate below kind of the average, but this is the point where, nope, this isn't acceptable. So we can move to that upper right-hand corner where we do kind of the quality assurance approach and just try to lop off that tail, which then mathematically moves the average or mean, the little green arrow, to the right. So the overall care, if you calculated it mathematically, gets better. But in reality, we haven't really changed the care that most people are receiving or the performance of most people. What we're really trying to do with quality improvements or performance improvement is we're really trying to do what's on the bottom right-hand side. We're trying to shift that whole curve over and make that curve narrower. So we have more consistency in our performance, and our overall performance is continuing to improve. So I always think, I guess I'm just a visual person, but I think it's helpful to kind of ground in that difference between kind of monitoring and actually improving. Here's another diagram that I think in my mind helps, for this idea of performance improvement, performance monitoring, and quality improvement. And this is actually a slide that comes from the Washington State Department of Health. I don't think I have the little logo on there. It maybe fell off when I moved it from one to the other, so hopefully no one will catch me for copyright infringement on this one. But the thing that I like about it is it really puts this quality and performance improvement in the bigger business picture, the bigger picture of an organization. And so as I think about working with a critical access hospital, at the end of the day, the real thing that they're trying to do is they're trying to produce results for their patients, their customers, their partners, the people in their community over on the right-hand side. In order to do that, you start on the left-hand side with your goals, objectives, missions, values, your strategic planning, and then how you bring that to life is through monitoring your performance, kind of those bigger performance measures, similar to what I see some of the measures, the Flex program measures, the MB Equip measures, and then how to really make those changes in process is in the inside, in those quality improvement projects or process improvement opportunities. How do we really change the way we're doing our day-to-day work in order to then move those larger performance measures that we believe are then going to result in improvement for customers and stakeholders, and then learn from that as we go so we can feed that back in our strategic planning. So it just, like I said, is another that helps me kind of put this concept of how we marry kind of this idea of organizational performance with some of the quality actual improvement initiatives that need to happen at the organizational level to really make a difference in the measures that we're using and the results that we have for our patients. So, improvement. Yep.
Can I interrupt you real quick and just?
You can.
We also have the opportunity on the left-hand side. There's a chat feature where Scott Daniels has put in a question, but I'd like to encourage others to do so, just so we're able to ask questions. And he asked, so in QA, you see a change in the mean, but not necessarily the median?
Yes. The mean, mode, median, and that's kind of the difference. It's when you look at the math. Yeah, you're the height of your curve, where most of your results are, really doesn't necessarily change by just lopping off those providers that are falling below that minimal standard of care. But if you looked at the average or mean, you could see an improvement. So it can be a little misleading, and so that's why I think looking at that curve kind of helps me ground in, okay, it's not that quality assurance isn't bad, because you certainly don't want people falling off that left-hand side, but it doesn't necessarily move overall performance ahead. Does that help? So I just wanted to take a little dive back into some history, because I think it sets the stage for, why improvement isn't a task or a series of tools, but it really is how we do our work. So just a quick little dive into some of the work of three names that you probably recognize: Edward Deming, Walter Shewhart, and Joseph Juran, or at least recognize some of them. There's certainly others There was Donna Bedian, who was kind of the person who focused on structure, process, and outcomes in the healthcare role. There was Ishikawa, who was big with the cause-effect and fishbone type of things. But I just wanted to focus on these three because I think they set a little bit of this history for the interrelationship between quality and the philosophy and the science and how it's bigger than just working on projects. So let's just start with our buddy Walter Shewhart here. He was a physicist. He worked at this Western Electric company back in 1918, and they did telephone hardware. I'm sure they're probably long out of business by now in the age of cell phones, but it was this interesting place because this is where Shewhart and Deming and Juran kind of all overlapped and touched each other. But things that you'd recognize Shewhart for, he was the one who developed the first control chart and kind of this launched statistical process control and quality improvement, which we don't use as much in healthcare. I think that's probably could be a topic of another talk because I think using that philosophy more would help us in measurement, but we don't usually come from the engineering background. We come from healthcare backgrounds, and so we're not as comfortable with that kind of approach to measurement. But that really led to this idea of the special cause and common cause variation and identifying those categories. He developed the PDSA cycle. He called it the Shewhart cycle that combined that how do I manage change along with statistical analysis. And he's the one that looked at the Hawthorne effect, which you guys probably have heard. It's kind of that idea that, simply by looking at a problem, you can make a change. So if you pay attention to something, people's behavior will change, but that's not necessarily a real change, and that's why we need measurement, statistics, and those type of things, because as soon as we focus our measurement on something else, that performance will probably go back to the way it was before. Then we have Joseph Juran. He's a Minnesotan, also is an engineer, and he worked at this Hawthorne plant in 1924 to 41. And what he added to this whole equation was he really decided that, quality at that time was statistics and production techniques. And he said, yeah, that's part of it, but we really need this human factors piece, especially management. And we really need to understand that quality problems are something that need to be solved systemically. They're not something that we can just, we have to look at this bigger picture. And so he developed this Juran trilogy, which is this combination of quality planning, quality control, and quality improvement. He also took the idea of the Pareto principle and applied it, which we've since applied to healthcare. Pareto was this Italian economist who said at the time that 80% of the wealth in their country was held by 20% of the population. And Juran flipped that to say that when you look at quality problems, 80% of the problems were due to only 20% of the causes. And so therefore, we need to find those 20% of the causes, and that'll help us solve 80% of the problem. Don't focus on all the little things down the line that aren't causing, that aren't where the kind of the big wins are. Oops, I'll find my little clicker here. And then he was also really heavily influenced by some of the Japanese post-war economy, and that really kind of helped. He did a lot of work over there. In 1979, he founded the Juran Foundation. He was also one of the people that was very active in creating and supporting the Malcolm-Baldrige National Quality Award, which I know from talking to Caleb that that's something that a lot of your organizations have been working on. And in 1997, we now have the Juran Center at the Carlson School of Management. And here's a little picture of all the little Juran artifacts at the Carlson School of Management. And Juran's probably another, is an example of why quality improvement is good for all of us. He died at the ripe old age of 104 and was determined to be a sacred treasure by Japan for his work. So a lot of good stuff that Juran did. And then finally, Edward Deming, common name in the quality world. He's also an engineer and a physicist, also worked at the Western Electric plant. And the interesting thing about him is he, apparently Shewhart, really bright guy, but he wasn't really able to tell a good story. So he had all these ideas but couldn't really communicate it to people. Deming apparently was much better at putting his ideas to words. So that's a lot of times why the PDSA and some of those things are attributed to Deming, because he was the one that was able to really help say this is how it works and have it make sense to people. Now, if you go on and you Google presentations by Edward Deming, you listen to him and you say, wow, he's really hard to listen to. Shewhart must have been really hard to listen to. But just kind of an interesting history. He then, again, worked with the industry in Japan and Ford Motor Company and founded the Deming Institute. So why in the world am I going on about all this stuff? The end result, a couple of the end results here is Edward Deming developed the system of profound knowledge, which consisted of 4 parts. One is the appreciation of the system. And that was that we really need to understand the connections and interactions between our systems and processes within our organizations if we're really going to make changes and do better for our customers. He also talked about variation, that we really need to understand variation. What's causing this variation? I see this a lot in organizations. They do these lovely run charts that bounce up and down and up and down and up and down, and when they're above the line, they're green and all is good. When they're below the line, they're red and all is bad. And they're chasing this around. And Deming really said, no. Got to understand what's causing that variation. Don't just chase the ups and downs. Understand what is that common cause that's built into the system and what are those special causes that are coming from outside your system. He also talked about this theory of knowledge, and that is that management, and this is really where he starts to get into, quality isn't just about the folks working on the front line and putting the door handle on the car correctly. Quality is really about how these organizations are managed, and that management shouldn't just say opinion is fact. We believe that da-da-da, so therefore it's true. But instead, we really need to build our whole organization on, the idea that we need to test our observations, our opinions, our beliefs, and we need to look at data to really say, is that really true? Is it really representative of what's going on? And do we really understand the situation? And then the knowledge of psychology, of really saying, what is it that we can do in our organization to motivate people to do a good job? That most people generally want to come to work to do a good job. They don't come to work wanting to do a bad job. How do we help that? How do we have a positive approach to our performance and helping the people take pride and independence in the work they're doing? So he came up with the 14 points of management. Many of you may have seen these before. I think they're still really relevant today. And I think and the reason I put this here is I think as all of us, as we're working in the QIO, as you're working in the Flex program and trying to help other organizations make improvement, not a bad thing to look back on and to say, as we're trying to decide what are those activities we can do, what are those interventions we can do, how do they fit with some of these points of management? Are our activities really moving people ahead to be able to do their work better? are we breaking down barriers? Are we supporting teamwork in order to make our measures better, in order to make our product better? So that's kind of my little setup in history. So why in the world was that important, and why did I need to talk about it here? I think it really highlights the intellectual foundations of improvement. I think sometimes it's really easy for anyone working improvement to start to think about it as a task. Well, we have these measures, and we just need to get better at the measures, and we'll do a PDSA or an RCA, and then our measures will improve. And really, it's not a task, and doing a PDSA or an RCA isn't doing improvement. It's a tool that we can use to learn about what is happening, and it's tools that we can use to learn to find out if this change would actually make an improvement. But in and of themselves, they're not necessarily improvements. And likewise, it's that, you know, these individuals in history didn't envision improvement or quality to be just a task or the role of the QI or PI team. They really envisioned it as a management philosophy, that this is the way we need to help support these organizations, whether it be a critical access hospital or whether it be clinics or anything like that, how we help support them to have this philosophy as how they actually approach their work. And that to the tools and techniques are very helpful. They're foundational to how the work gets done, but they are just a tool and technique. So it's more of a philosophy and a science, as well as some of the models that we talk about. So let's get into what we want to talk about here. So some of the things I think that healthcare can learn from industry, because when you look back at all these guys, they were physicists and engineers, and they worked on ball bearings and making cars and things like that. It's a whole lot different in many ways than what we do in healthcare, where we have patients that aren't, don't always follow their exact model of what their illness or their condition is supposed to follow, and we have a lot of people working in healthcare that we hire to work in healthcare because they're supposed to use their critical thinking skills. They're not just supposed to put a handle on every door that comes by. They're supposed to do an assessment and, based on their knowledge, use that best decision. So it's different, but I think there's still things we can learn. And one of them is just the attention to customers. Is the work we're doing really hitting at their values and expectations? This attention to system design and processes. The greater role of management in quality. And I think sometimes that happens, sometimes it doesn't. I think a lot of times it's easy to have quality be pushed off to the QI team, and that QI team reports to management. I think we could do better at our statistics, and if we utilized or got better at looking at some of the statistical process control techniques, it would help us in our measurement, and just that greater education and training and improvement for all staff. So here's what I'd like to kind of walk through for the rest of the time, some of the things that I think can help us do this. And that is, taking the time to really define the problem, knowing how to use QI tools and putting them into their perspective, linking our actions and outputs with outcomes and impacts, understanding measurement, and then the balance of time between this monitoring, controlling, improving, and innovating. So this is one of these quotes. I don't know if you're on Facebook or social media, you often see quotes fly around. This is the one: if I only had 1 hour to solve a problem, I would spend up to 2/3 of that hour in attempting to define what the problem is. It's usually attributed to Einstein, but I looked because I didn't want to quote and give Einstein credit for something, and apparently when we look back, there's really no evidence that Einstein actually said this. As with a lot of things, there's a lot of quotes that are attributed to Einstein that he didn't really say, but they sound really smart, and he was really smart, so heck, he must have wanted to say something like that. This was apparently, I think, some person from an engineering department someplace or another, electrical engineering department of Yale. But I think it really speaks to work in improvement. A lot of us that work in healthcare, we're doers. We want to get something done. We want to we want to get to the intervention. We want to measure. We want to move upstream. And we don't spend the amount of time that we really need to in setting up and understanding what is it we're trying to accomplish, what's the actual problem we're trying to solve, how does that actually link with what we're putting into place, and how will we know if we actually made an improvement. So it's a good thing to keep in mind that it's kind of easy to confuse problems with solutions. One of my mentors at the university always used to say, and I'm not going to quite say it as articulately as he could, but we just often make the mistake of implementing a solution before we've clearly identified the problem. And it's just so easy to do that in healthcare, and it's especially easy to do that when we're given measures to accomplish, and we get focused on, well, here's the solution, but we have to figure out how do we really go backwards to understand what is that problem we're trying to solve. Because it gets harder the farther away you get from the action. So I always like to remind people, no matter what level you're working at, if you're working at the organizational level, if you're working at a programmatic level, if you're working at a project level, taking time to really articulate what the heck am I trying to do here. I say a problem well stated is really half solved. Because if you can really truly articulate what you're trying to solve, you're well on your way to figuring out what's the best way to attack that. It also helps promote a common shared understanding of what you're working on. A lot of times you have to gather information, and that's where kind of that, it may take 2/3 of your time to really get your problem figured out, but by the time you've figured out what's wrong, when does the problem occur, how big is it, what's the real gap, and built all this, you've already set yourself up to very well understand some of the things that could really make a difference and really impact, have an impact on the and create an outcome or an impact. I'll get it right yet. And so this is just the kind of generic elements of a problem statement, something to keep in mind as you're working. I pull this out a lot and force myself to go through, step by step. What is it? What's the dates? What's the specifics? What is it? What's to quantify it? Am I quantifying it in time, dollars, errors? What's that measure? What's the metric of it? What's that difference between where the current performance is and where we want it to be, and what's that impact of the problem on our customers, the organization, whoever the end point is. The other thing is really knowing how to use your improvement tools. And so some of the things, and we're not going to dive into all these today, but a lot of these are things that I'm sure you probably talk about in your work, or a lot of the hospitals are familiar with. You've got the tools that help you with that planning piece, like your failure mode and effect analysis, or FMEA, root cause analysis, or RCA. The tools that help with actually making an improvement in process, like your PDSA, process mapping. And then the things that are kind of more in that monitoring and controlling piece, checklists and audits. Are we doing it the way we want to? and making sure that you really know how to use these tools, that you can actually pull them out of your toolbox and be effective at helping people utilize them well. But the corollary to that is that these tools in and of themselves are not improvement. We had a person that was part of the CMS in one of the contracts we work at that would always say, well, just do PDSAs. Just do more PDSAs. And kind of missed the whole piece that, yeah, I could do a PDSA on something, but unless I can put that PDSA in the bigger picture, in this bigger understanding of what I'm trying to accomplish, I'm just kind of randomly going around, you know, moving things from one place to the other. I don't have a purpose. I don't have a direction for that PDSA. And I think sometimes people think, oh, you know, these tools are, maybe they're too complicated or things like that. You can use these same tools in any setting, whether you're a critical access hospital or whether you're Amazon.com. It's the same tools you're going to use. So either they're not rocket science, they're just tools. As you get comfortable with them, they're easier to use. And often more than one tool will work for you to understand the problem. So the more tools you have in the toolbox, the easier it is to pick out the one that you'd like to use in that situation. Model for improvement, I just put this here because I think it does try to get at some of this idea of upfront asking ourselves what we're trying to accomplish, how we know that change is improvement, what change can we make before that will result in an improvement, and then the PDSA cycle, which helps us actually make process improvement changes. And the nice thing, as you probably all know about the PDSA, you can do that on a smaller scale. And so I think that's a lot, especially in critical access hospitals as you're working with them. It's a great tool when you've got small numbers and you're trying to determine, will this actually have an impact in a setting where maybe we only see one case of this every 6 months. So how do we link this back to output and outcomes? When I was talking to Caleb, he said you use logic models, and I also, my next slide is actually Carla pointed me to some of the logic model examples that are out on the Flex website. But I really like this idea of a logic model. Now, it may be because I like Shewhart and Deming was a physics major as an undergrad, and I'm it trained me to be a very linear thinker. I'm also one of those people that loves word problems because I love to set up the problem and I love to set up the equations, and then I like to make the solving of it just as pretty and clean as I possibly can. And so that's kind of maybe just the way my mind was trained to work. But I think the logic model is such a good tool because it really forces us to create those alignments that we need to have as we move from, okay, what do we have available, to what is it we're really hoping to accomplish in the long term. Because if we don't link those activities, the output of those activities with the outcomes, we have no idea if we're really ever going to get to that impact. And we may use a lot of extra time and energy doing things, giving education, doing things like that, that maybe aren't necessarily linked to the outcome that we want to have happen or the impact that we want to have. So I'll just walk through quickly here, and you're probably familiar with this, but just in case you haven't looked at the logic model for a while, the inputs to our logic model are just those resources, and those are usually a noun of some sort. I've got either, I've got textbooks, or I've got something that's available to me. I've got data, I've got people, I've got things like that. What are those resources that I can call on? And now, so what do I want to do with those resources? So that's usually some type of verb statement. I want to analyze that data, for a real simple one. And then what's that output? What's that volume of work that I want to have done as a result of that? And that's usually some kind of quantity. I want to, with that, create 12 12 different resource guides for some issue. And then what's that outcome? So as a result of creating those resource guides or education, what do I really want to see change? What am I going to look for? What's going to really be different? And so that's being able to say, what's that change that's going to be there? And then, okay, now what's that long-term impact? What's really going to be the thing as I look out several years? I'm going to see that the world is different because we did these things. And so this was just the Flex program logic model, laid out just a little bit different than what I put together, but it's really kind of the same idea. You have, so the measures you're working on, is what you kind of put into it. So what's the output that you're going to do? What kind of activities? So you maybe are doing some kind of events. You may be doing some training. You may be creating some product, some resources for hospitals to use, something like that. And then what's the result of that activity in the short term going to be? What's the result? What's that behavior change that's going to occur? And what are those long-term things that are going to happen as a result of that? What's going to really happen as a result in quality of care or behavior of workers, or how's it really going to change the process of care in long-term care in a way that then impacts the health of the population in these communities? So just to kind of go through, so some activities, like I said, they're usually the inputs or resources we have available. So for example, chart audits. We might obtain feedback. We've got some survey results. We maybe have a synthesis of literature related to a topic. We have, we're going to prepare education or other resources. So that's some of the things that we're going to do with these, with those inputs we have. And then some of the outputs that we can have. So as a result of those activities, we maybe are going to be able to provide monthly feedback to prescribers on their antibiotic prescriptions. Or we're going to deliver 12 educational sessions on fall risk screening. So we put all this, we gathered this information, we then put that information together in a way that we can now give it out to people. So that's the output of our work. And then our outcome. So the changes we want our activities and our outputs to make. So we really want to say, so who do we want the change for? What will the change be? And in what way should there be a change? So I tried to pull maybe, a hospital focus. So maybe the outcome is we want 75% of hospitals that are participating in the specific activity to see on a return on investment of at least 5%. So that's really the outcome piece. And I think this is where it's this output and outcomes that people get a little muddied up on. A lot of times people think that we created education and then that's an outcome. That's really an output, and it's really saying, okay, so our education is designed to do such and such. I don't know if any of you are familiar with Bloom's taxonomy. I had the opportunity to teach a class a couple of years ago at the U, and had actually a Bloom's taxonomy nightmare, because one of the things in education that you have to do is create your objectives, and then your objectives need to align with the resources that you use, and then those resources have to align with the material you're going to present in class, and then the activities that you're going to do in class, and at the end, what is it you want the student to be able to do with it? It's really another form of a logic model, just with different words on it. But the Bloom's taxonomy really helps you put the right words in place. So I want people to be able to recognize, or I want them to be able to analyze, or I want them to be able to design something, or I want them to be able to change. And depending on what that thing is you want them to be able to do, it really helps you then say, okay, that I have to do this activity that creates this output that really then allows for people to do this. So it's just, I always find it fascinating that whether it's quality, whether it's education, all of these things, we really can use this same model, and it's really, in order to do this well, it's really training ourselves to do this kind of linkage and alignment in our mind. The other thing is to remember that these outcomes, oftentimes when we're working on things, can be directed to different levels. So we may have outcomes that are at the hospital level, or directed towards patients and families, or we may have things that are directed at a group of patients, say a group of people, say we have patients that have cognitive impairment, or maybe an organization. This is where the outcomes are directed at. A lot of what you're doing is directed at organizations, is my understanding. Ideally, this would then, thinking back to that first diagram, they should then help link this back to their mission statement or strategic plan, or it can be linked to the community. And some of the things that a lot of the hospitals are doing, and you're helping hospitals to do, in my understanding, is link this back to the community as well. Impact. This is the one I think that's the hardest, because it's those big pictures, and that's really kind of what can fundamentally be different because of this work. And oftentimes it's really hard for us to measure impact. So I was looking at some of the measures that you have. So I was trying to say, okay, so how do we really put some of these in this impact, in this, how do we really tease out what the impact of it is? So patients presenting with stroke symptoms can receive a CT or MRI reading within 45 minutes of arrival to the emergency department in order to increase their eligibility for therapy and decrease the percentage of patients with resulting deficits from stroke. So what we're really trying to do is really saying, how are all these, at the end of the day, are we decreasing the amount of people that have deficits from their stroke by being able to meet these measures, and are our outputs and outcomes really helping us meet those measures, so then we can align that better with our impact. The other thing about measures, and this is just a little piece here, they're different but complementary. And we often talk about is measures for accountability. And I think this is important because as I look at the measures that the hospitals are reporting on, many of those are really these measures for accountability. They're very research-based measures that, when improved, have been shown to have an impact on patient outcome. Like I said, it's very hard to measure impact. And so in many ways, these measures for accountability are kind of our proxy for impact. We say, well, we may not be able to measure how many people actually don't have a deficit in stroke that would have had a deficit in stroke, but we're confident enough in these measures that if we can reach them, we think that that's what impact is going to have. And so they help us meet and there's often a criteria we need to meet for measures of accountability. It's a little different than the measures we're using for improvement, and I think that's one of the things that as we look back at the logic model and looking at that link between activities, output, and outcomes, that's where some of the improvement measures also need to link in. So how is this helping change process and outcome? And if you make any changes in those process, is there any potential adverse consequence? So that's where the balancing measure comes in. So it's really helping you look in that middle piece of what's the impact of those changes. So while measures for accountability, at the end can help us lead to improvement, they aren't the measures that help us necessarily on a day-to-day basis. And so that's where, as you're working with hospitals, really that's where the improvement piece, the performance improvement, quality improvement, and really being able to understand what are those measures that they need to be able to do to really look at, are they changing their process, are they changing their systems in order to have an impact on these measures for accountability. Sarah just said the framework for defining change by who, what, and in what way is nice to think about defining outcomes. Okay, good. I'm glad it makes sense. And then I just wanted to kind of point out to the goals and measures. I know I'm sure you've talked about those before, but I always like to put in a pitch for, we want to have overall goals and measures, and they can certainly be at this overall program level, at the individual kind of project level, and we have goals and measures for our activities, our outputs, and any improvement work. And again, it's just that really being able to kind of clearly define what you're trying to accomplish. Another thing that can be helpful is the SMART formula. You may have seen this or you've worked with this before, but another kind of good checklist to help you frame things up so that when you're trying to say, here's what we want to do, kind of forcing yourself to say, is it specific? What do we want to accomplish? Who will be affected? Where will it take place? Is it measurable? What are we going to use to measure it? What do we want to increase or decrease that measure to? Is it attainable? Is there a best practice or an average or a benchmark? You don't want to make it not challenging, but you also don't want to set something that's totally unreasonable. And then you want to make it relevant. I always say, if I'm talking to a customer and I say, hey, we're really going to work on this, and they'd say, oh, yeah, that'd be great. As a customer, I'd really appreciate that. That's what you want to kind of have as your litmus test, and to give yourself a time frame to get it done in. And so just an example here, in order to prevent wrong site surgery and protect patients from additional procedures, the use of safe surgery checklists will be increased from 70 to 95% by July 1st, 2018. So specific, we're talking about increased use of checklists. Measurable, we're trying to 70 to 95%. Attainable, yeah, we have good evidence that, yep, people can do that. Relevant, and that should tie back to your problem statement, and we have a time on it. So kind of a simple concept, but a good thing to always keep in mind. Some of the challenges with measurement, really easy to get hung up on measurement. We don't often tease out common cause and special cause variation. Run charts are great, but they do have their limits because I have seen too many organizations chasing red balls and green balls for whether they're above or below their goal, and 1 month they're above, 1 month they're below, and you really have to be able to understand, is the change that you're seeing in your run chart or in your data a real change, or is it just part of what you would expect from the normal variation in your process? Control charts are better, but they're not as easily taught. And maybe this is an area, as I tell you, I work a lot with long-term care, which certainly, like critical access hospitals, often don't have people are wearing multiple hats and don't have a measurement expert. Sometimes this is the place that you just ask for help, and you get an expert to help you here and say, what is the best way to measure this? Because we don't want to be chasing our tails. We want the data we're collecting to really be telling us whether we're making an improvement or not. And then kind of finish up, my final slide here is back to thinking about that controlling, improving, and innovating, and those initial little bell curves that I showed you. That idea of control where we're trying to monitor for, are we falling below our minimal our minimal threshold of performance, or a threshold of performance that we've set for ourselves, should really be a small amount of what we do. Sometimes we spend a lot of time monitoring and thinking that that's somehow going to help us improve. It doesn't really help us improve. It just tells us if we're falling below that threshold. We want to spend the bulk of our time in actually looking at how we can do it better, looking at our data to say, yep, we're here, but where would we like to be? Where could we move to? And ideally, leave a little bit of time for innovation to say, what could we really do different here? How could we kind of really take what we have and look at it in a different way? How could we better meet our customers' needs? And so I think